Hey, hi, everybody. I'm Harriet Esdale. I'm a diabetes and endocrinology trainee in Northwest. Thank you for attending the Diabetes Masterclass today. It's a real pleasure to have Dr. Andrew Frankel talking to us about diabetes and CKD. Dr. Frankel is a consultant nephrologist at Imperial College Kidney and Transplant Institute. So over to you, Dr. Frankel.
Okay, well, thank you, Harriet, for inviting me. And I gather we've got a good audience coming in remotely. It's a real pleasure to be here. This is broadly what I'm going to try and cover. A couple of key points. One, I will go through a lot of slides. For the slides, do not worry too much about the detail. I will give you key take-home messages that you need as a trainee. Two, it really does need to be as interactive as possible. And of course, you're all doing this from home or from other places. Please ask questions on the chat, interrupt me if necessary. We'll get as much of this done as we can, but I'd much rather that we actually involved you. So I'm going to cover the basics, management of diabetes and kidney disease, and I want to spend a bit more on, particularly for you, obviously, glycemic management and nuances that you need to be aware of when dealing with people with CKD. I wonder how many of you actually know what the definition is. Since I've got presenter view, you get a real help here, but you really do need to have fixed in your mind what we mean when we talk about CKD, because CKD is a very specific disorder that is coded in primary care on the basis of this: the presence of markers of kidney damage that are present for greater than 3 months, and that could be structural or functional, relating to GFR, and it could relate to other markers such as the composition of the urine, such as albuminuria, and it could consist of altered structure of the kidneys. So you either have to have a GFR of less than 60 for more than 3 months, or a GFR of more than 60 in conjunction with albuminuria, hematuria, or structural kidney damage. That is the definition. So I think it's important you know what we are dealing with. I've got a case here is purely to just introduce the whole subject. And this is a very typical case. There's probably about 100 things to discuss about this case. I hope we'll cover much of it in the talk. 69-year-old Caucasian female, originally from Poland, now living in South Acton. And I discovered today that Polish is the second most common language spoken after English in Northwest London. She's had 5 years of type 2 diabetes. Please remember, I know you will know this, that's 5 years since diagnosis. We do not know how long it's been since she developed the disorder. She's had retinopathy which is screened for background changes. I would like you to take away one of the messages I'm going to give you about retinopathy. You always hear about retinopathy and diabetic nephropathy going hand in hand. With type 2 diabetes, that is less consistent. It's definitely consistent with type 1. If we get time, we might want to talk about that. What she does have is non-alcoholic fatty liver disease. And indeed, what we are now seeing in people with type 2 diabetes and who develop cardiorenal metabolic complications, they often have non-alcoholic fatty liver disease. BMI 38, very common, probably obesity-driven type 2 diabetes. Blood pressure 165/92, so a little high. 1 plus protein, 1 plus glucose. ACR 35, repeat 40. Why did I repeat? You might want to have a little sheet next to you where you answer the questions and test yourself. Repeated because NICE guidance says if it is less than 70, so between 3 and 70, you must repeat it, ideally with an early morning sample. If it's more than 70, you do not need to repeat it. She's got abnormal kidney function. GFR is 35, with creatinine 160. Question: do you think that GFR is accurate? Answer is no, because she's got a BMI of 38, and therefore that GFR is an underestimate of her real kidney function. Please remember, we may not be covering this, that GFR is not a brilliant or sensitive marker of kidney function, particularly at extremes of weight. Glycemic control, HbA1c of 68, non-HDL cholesterol 3.1, and she's on ramipril 10, irbesartan 75 BD, simvastatin, aspirin, gliclazide 80 BD, and linagliptin. Please take note of that. So let's think about her staging of CKD. And I'm going to give you a diagram of this. To some extent, as diabetes endocrine trainees, I don't expect you to worry too much about this, but you'll hear about it. So just top-line knowledge on staging. What do you think is the diagnosis here? Is this diabetic kidney disease? Or, as you always need to think, could I be missing something else? Assuming we decide it is, what needs to be monitored? How would we best manage the blood pressure? Is the current drug regimen appropriate? What about the glycemia? How is that best managed in someone with diabetes and kidney disease? And what else might this patient have? So let's go and think about those questions. So CKD is staged, and this is for primary care purposes. It's a public health tool on the basis of the GFR. So you have a G number and you have an albuminuria, an A number. And what I want you to notice, will they be able to see my arrow, Harriet?
Yes.
That as you go from normal GFR and no albuminuria down to decreasing GFR and increasing albuminuria, you see increasing color here to red, increasing risk. Question: do you understand what those risks are? Those risks are increasing likelihood of cardiovascular disease, increasing likelihood of progressive kidney disease, increasing likelihood of end-stage renal failure, but also increasing likelihood of acute kidney injury occurring. Please remember that, as I said, it's a continuum, but we use this tool. And it's a risk prediction tool. CKD has many causes, the majority of which at the moment are non-diabetic, but the diabetes as a cause of kidney disease is increasing year on year. And if you look at the renal registry, the number of people on dialysis because of diabetic kidney disease has increased every year that the registry has been running, and it's now 30%. In places like Hammersmith and Fulham, or Imperial, Leicester, Birmingham, it's actually 50%. We are the end-stage kidney disease capital of the UK, and some of our boroughs have the highest instance of end-stage kidney disease, which is a marker, a surrogate marker of CKD. And Brent, sorry, this is 2016 data, the current data is not much different. Brent has the highest, in that year, had the highest incidence of kidney disease in the UK. It's usually between Brent, Ealing, and Leicester. Why? The answer is the population we serve, the high ethnicity with a high incidence of diabetes, and the significant social and health equity issues that we see in some of these boroughs. So you, if you're going to be working here, will need to know about this, and I'm sure you do when you go on the wards, because you see many of your patients have CKD. I just want to very briefly, and I'm not going to labor this, it's really important that you are attending this session, because however bad it is now, it is going to get worse. And the reason for that is the following. Please remember, diabetes is becoming the commonest cause of kidney disease. But to develop kidney disease in the context of type 2 diabetes and type 1 takes time. Generally for type 2, We see it about 5 to 10 years after diagnosis. And what you're therefore seeing now is a cohort of people who had type 2 diabetes 10 years ago, when the numbers of people in the UK with type 2 diabetes were significantly less than they are now. So the figures of what we have now, you will see that population of developed diabetes in this last couple of years gestate to cardiorenal metabolic damage over time.
A question from the audience.
Great.
Will be compared to East London.
Oh yeah. So there is a bit of a so East London, you're absolutely right. Tower Hamlets have a very high incidence. We generally beat them, but you're absolutely right. The point you're making is that East London has similar ethnicity, slightly different ethnic mix, and social issues. They have a very high high incidence as well. Coming back to this point, I just want to highlight to you that because of the growing denominator of people with type 2 diabetes, and I'm not going to labor this, but because of the length of time people are now living with their type 2 diabetes, because of the fantastic work done by our cardiology colleagues and primary care, you can see that the number of people with renal replacement therapy because of diabetic kidney disease is increasing. Predominantly, this is because of diabetic kidney disease. And the prediction is that this will continue upwards into the late 2030s. So be aware, this is not going to go away, even if we do everything perfectly. The next slide is just to get across a single point. I used to come to this when I was invited 10, 15 years ago and give a talk on something called diabetic nephropathy. And I used to show pictures of glomeruli with glomerulosclerosis, and I used to talk about the science. I would talk about what drives diabetic glomerulosclerosis. I don't talk about that now. I talk about cardiorenal complications of type 2 diabetes, because that is really what we are seeing. We are seeing microvascular damage caused by long-term diabetes and hypertension that expresses itself as CKD, but also as heart failure. And these three disorders, cardio, renal, metabolic, go hand in hand. There's a 5 times increased risk of heart failure with type 2 diabetes. And I know many of you now don't look after type 2 patients on your week-to-week clinics, but if you speak to the diabetic nurses in the peripheries, what they are doing now is they're asking questions about breathlessness. They are screening for heart failure and they're picking it up. And then about 40% will have CKD, but there's extremely common, the two things go together, CKD and heart failure. So please think about type 2 as CKD, heart failure in association with diabetes, and probably, I would say, non-alcoholic fatty liver disease. And this is also something I think will change. At the moment, and I will take you through this slide, if you develop kidney disease in the context of diabetes, we say you're more likely to die from cardiovascular disease than end-stage kidney disease. And you can see that here. Just look at the blue boxes of people who've got CKD with a GFR of less than 45. If you follow them up, the rate of end-stage kidney disease per 100 person years is 1.8, but it is significantly greater if you're looking at cardiovascular and non-cardiovascular mortality. My prediction to you is that in 2035, we're going to see those rates equalize because people will be surviving longer. So this whole bit of this has been, you need to know about this disorder because it's common now, it's going to be even more common. Think about it as cardiorenal metabolic. How do we recognize it? So a 53-year-old man presented to his GP with an inguinal hernia, 6-year history of hypertension, treated with atenolol. He's never visited a doctor. This is very similar to many of the patients I look after. Never visited a doctor, never picked up a prescription, smoked 30 cigarettes a day, blood pressure 176, 496. He's got bilateral block hemorrhages, microaneurysms, and hard exudates. So he's just got a history of a hernia and high blood pressure, fasting blood glucose 16.7, urinalysis 4+ protein, 1+ blood, creatinine 176, ACR 287, ultrasound shows normal sized kidneys. This is a question for the specialty exam for renal. What is the most likely diabetes? Okay, diabetes and so let's just explore that. That's really interesting. Are we going to go back? Yeah. So 53, yes, it's got hypertension, and you're reasonably, it's reasonable to think about hypertension. But what we now know, obviously, this guy's been sitting there with diabetes for a number of years. He's got a random fasting blood glucose of 16.7. You know that means he's got diabetes. And those fundoscopy findings, even though I told you they're not always as consistent, so I probably need to talk about fatty liver with this patient, but he's got fundoscopy findings that are actually more consistent with diabetic changes. And the likelihood is that this guy has got diabetic kidney disease. We would want to rule out other causes of kidney disease. Now, you are not going to refer every patient like this to me in my clinic. You may want to ask us, and we do have MDTs, we have e-advice lines. But essentially, you suspect renal disease other than diabetic kidney disease. And I think this is an important slide. I'm very happy to share my slides. We'll talk about this as a PDF, but this is an important slide for you to have in your back pocket. If there is no significant or progressive retinopathy is a traditional statement. As I've said, I'm beginning to be a little bit more iffy about this as I get older. The blood pressure is particularly resistant to treatment. They're on 4 agents. They previously had a normal ACR and rapid change, because diabetic kidney disease progresses very slowly and progressively over time. Of course, you don't have that figure for this man. I get that. Significant non-visible hematuria, and 1+ hematuria is not unusual in people who've got histologically proven diabetic glomerular sclerosis. A more accelerated decline in GFR. They have systemic features that suggest they've got something like a rheumatological condition, or they have immunological abnormalities. So we might biopsy this guy. I probably wouldn't. It'd be perfectly reasonable because we don't have the background history. We don't know how he's got to where he is now. As I've said to you before, association of heart failure and non-alcoholic fatty liver disease, for me, makes it more consistent with cardiorenal metabolic disease. So do some immunological tests, try and get that history from the GP about their albuminuria and their blood pressure, dip test the urine, ask them a good history about systemic features. So let's now move on to what we do. I almost don't want to actually cover this. This is really going back to me in the 1990s. This is how we think about disorders, the pathophysiology that leads to diabetic kidney disease. And they are almost certainly based on endothelial injury, oxidative stress, hyperfiltration, and inflammation. Please, it's taken us many years to appreciate that diabetic kidney disease is an inflammatory kidney disease.
Can I ask you a quick question?
Yes.
But what you've just said is diabetic kidney disease as an inflammatory disease. So in Ground Round earlier today, we heard about the complement inhibitors that are used in certain types of glomerulonephritis. Is there any role for targeting?
So the answer to that, so the question asked was, is there any role for anti-inflammatory? The answer is that there has been studies looking at agents that are anti-inflammatory, bardoxolene, and there's an MCP1 receptor agonist that's been trialed and has shown beneficial effects in relation to albuminuria, but there is no good phase 3 data that shows good hard renal outcomes at this stage. And I think it's because of the complexity of that pathogenesis.
Thank you.
I want to talk a little bit about hyperfiltration, because this is a very important driver of diabetic kidney disease. It's driven probably by hyperglycemia and its effect. It leads to ultrastructural changes within the glomerulus. Don't worry too much about this slide. I'm going to take you through it. And I'm going to explain this to you so you can get an understanding of this. And it's believed to be related to tubular abnormalities. I'm going to actually show you some slides on this. What I think that many, and I'm going to put this slide up to completion. This is something many physicians and GPs don't actually get. As diabetologists, and endocrinologists, you know about the concept of hyperfiltration as an early feature of diabetic kidney disease, particularly in type 1. That when they present, they often have GFRs that, if you measure them by nuclear medicine, are not 90, but they may be 120, 130, 160. They hyperfiltrate. And that is a sign of impending trouble because it's usually associated with low-grade albuminuria and then progressive decline. What I want you to get across from this slide is that hyperfiltration and the glomerular hypertension that's associated with it continues as the GFR drops. So as you start hyperfiltering and you lose glomeruli, your remnant kidneys still are working harder. They are still hyperfiltrating. They still have a high glomerular capillary pressure, even down to a GFR of 25. Each individual glomerulus within those remnant kidneys are hyperfiltrating. So I want you to get that concept in your mind. So this is the management of DKD as we are in 2022. Actually, it's not, because I'm going to add something to that. Key message, one, recognize, and I'm going to go to the next slide and come back to this, and recognize early. The earlier you can intervene, because our treatments only slow the deterioration in kidney function. But if you look at this slide and you imagine, if you got that red point of that red line and you start it earlier, the time in which you can prevent the kidney failure is much greater. If you start that process further down the line, then you're going to get much shorter time because you will have the same effect on GFR slope. So recognize a lot of this has got to be done in primary care, and we're doing a huge amount with primary care to try and get them to recognize and go back to doing albuminuria, because it's albuminuria that is more sensitive than GFR. Then, once you've got albuminuria, that switches on this pathway. And what you need to do, once you've confirmed albuminuria or diabetic kidney disease because of a GFR change, you start on an ACE or an angiotensin receptor blocker at a maximal dose. So not 1.25 milligrams, please, of ramipril, 10 milligrams if they're robust, and get them there quickly. Obviously, if they're frail with heart failure, you may do that in a staggered way. Not two together. So that case I presented, some of you will notice, was on ramipril and irbesartan, which was in vogue in the years 2000 to 2010, but we now know does not provide benefit and increases harm. So just get them onto one agent, then get the blood pressure right. So what you often need to do is to reduce, if they're already on amlodipine or doxycycline, you need to reduce that to allow you to get to a good dose of ACE and ARBs. ACE and ARBs, blood pressure targeting, SGLT2 now, and we're going to talk a bit more about that, but that is to be used irrespective of glycemic control. It is to be used as a renal protection. Cardiovascular risk reduction. Glycemic management is more important in the early years. The bangs for your bucks once you've got albuminuria of bringing HbA1c down from 85 to 65 in terms of slowing down progression of CKD is much less than in the early years, but you will still get benefits in relation to retinopathy. And obviously you build that on a foundation of lifestyle, social factors, patient engagement, key. Can I just say, this slide was made about a month ago. I now have G, finerenone, and there will be on the ABCD site, appearing in the next week, I hope, a consensus statement on the place of finerenone, which is a new novel non-steroidal mineralocorticoid receptor antagonist. It's a short document, 4 or 5 pages, really worth you reading, because then you'll get absolutely up to date about the place of finerenone. And do look at the ABCD site, because everything I talk about is on there. And you will find guidelines for the management of hyperglycemia, blood pressure. You don't need to read these 90-page documents, but do be aware of the recommendations. Do look at our Northwest London guidance, which is embedded and is very similar to your Northwest London diabetes guidelines. I don't want to go through this in detail, but a lot of what I'm talking about will be reinforced if you look at the 5 or 6 pages of the Northwest London guidelines. So what about blood pressure? What target are you going to go for? Okay, well, the answer actually is less than 130/80. But actually, if I was to be really difficult, and when I change this slide next time, it's slightly changed. There's been a nuance. So let me take you through this. So blood pressure control, this is going back to studies done in early 1980s. I just want you to understand blood pressure is key to diabetic nephropathy in both type 1 and type 2. And this is just showing you the dramatic effect that blood pressure treatment had on progression of diabetic nephropathy in terms of decline in GFR and albuminuria. And this was using beta blockers and diuretics. This was before the age of ACE inhibitors. What is now recommended, and this is nice CKD, is there's no diabetes or proteinuria, 120/140/90. If there's diabetes or albuminuria, 110/130. So please note there's a systolic range. Okay, we are now trying to get people, you don't want the blood pressure to be too low, particularly if the person is elderly. And I'm actually not going to cover that. We got to get people on maximal ACE and ARBs, and I think I've highlighted this. Please be aware that one of the problems people with diabetes have, and particularly if they've got CKD, and particularly if they've got heart failure, is that they will get hypokalemia. They can get hypokalemia isolated without an acute kidney injury. And modern management is that we used to ask the nephrologist what to do, and we would pretend to be very clever. We would say, we'll put them on a low potassium diet, we'll measure the bicarbonate, we'll review the diuretics. We now know that none of those interventions really are effective. We now have new GI cation exchangers, not the calcium resoniums. We have butyramine and sodium zirconium cyclosilicate, and we need to be using these to maximize ACE and ARB therapy. What about glycemic targeting? I've already mentioned to you that in the early days of diabetes, particularly type 1 and type 2, and it's often never achieved in type 1, which is a shame, you've got to get that HbA1c right down. And if you do that, UK PDS showed definitively you'll reduce microvascular complications. Once you've got cardiorenal damage, you need to take your foot off the pedal. Key message here, that you need to be more liberal. And I just want to explain to you why. Because if you've got CKD, your instance of hypoglycemia is significantly increased compared to people without CKD. And that's even if you've not got diabetes. And what about hypo? This is something that people don't appreciate. That if you have an episode of significant hypo that requires assistance, you get changes in the vasculature and the platelets. You get endothelial dysfunction and you get a platelet dysfunction, which increases the risk of thrombosis and arrhythmias. What you may not appreciate is if you've had that episode of hypoglycemia, this effect lasts not hours, not days, but at least several weeks and up to 2 to 3 months. That's why people with hypoglycemia die of cardiovascular disease. And this is just saying why you get hypoglycemia, because remember, the kidney produces a lot of glucose, you get much less insulin degradation, you reduce drug clearance, and people don't eat as much. And often people get, as they approach end-stage renal failure, they can often come off of insulin because their glycemic control improves. These are the current ABCD targets. And I would highlight to you that once you're CKD 3 and 4, you should be thinking about a target 58 to 68 HbA1c. I want to now very quickly give you some takeaway points about glycemic control. And this is a great question. This is a great question, which we use in the membership for the nephrology. 69-year-old, type 2 diabetes, 10 years, retinopathy, on blood pressure treatment, metformin 500, simvastatin and aspirin. He's now got a potassium of 5, he's got a GFR of 17, HbA1c is 62, BMI is 32, ACR is 42. What are you going to do about his albuminuria? Let's go to the potential choices. Oh, sorry, I need to do that. So which of the following options would not be reasonable to recommend to the GP? Okay. Let me take you through this. And I go to my stat and I double click that. Okay. Well, this may surprise people, and it is important that you understand the answer to this question because you have to become the subject matter expert here. And although I've got some slides that demonstrate some of these messages, let me just take you through this, and I may then whiz through the slides so we get time for questions. Stopping the metformin is a good thing to do. The GFR is 17, so you need to stop the metformin because we do not recommend metformin below 30. The problem we've always had is what to substitute it with. The H1C is not too bad, so you could substitute it with a DPP-4, and that's what people have done. So sitagliptin at the right dose is perfectly acceptable. Remember, everyone thinks of Lina as the renal diabetes DPP-4. Sitagliptin is absolutely fine if you use it at the right dose. Stopping the metformin and substituting it for dulaglutide or indeed semaglutide would be perfectly reasonable because liraglutide, dulaglutide and semaglutide are actually licensed down to a GFR of 15. We have a lot of experience in using them. They reduce weight, they reduce cardiovascular poor outcomes, they're effective, so that would be reasonable. Going to D, pio would also be reasonable. You can use pioglitazone down into dialysis, and indeed there is some literature on using pio in dialysis. Remember though, people fluid retain, and if they are small frame, they can get increased risk of bone fractures. You could say, well, let's stop the metformin, the HbA1c isn't too bad, and let's see what happens. Some people are very metformin sensitive, and you find that the H1C has gone up to 85 2 months later. Some are not. The point here is that Cana has absolutely no glycemic effect at a GFR below 30 and minimal effect at a GFR below 45. The reason we are pushing SGLT2 inhibitors is because of their cardiorenal benefit. Once your GFR is below 45, they will have very little glycemic benefit, and you need to treat them separately as a cardiorenal drug than as a diabetes drug. Now, I'm not going to go through this in detail. It is all in the recommendations and the discussion. You don't need to read all of the 90 pages here. Just have a look at this. Let me just check. There's nothing here that I would want to highlight to you. I just want to finish by telling you, and I know you know this now, SGLT2 inhibition is the treatment now for cardiorenal metabolic disease. Please remember how it may work. Your glomerulus is shown here. You have your tubule, or your proximal tubule that contains SGLT cotransporters. The tubule comes back on itself to its mother glomerulus, and the distal tubule has this section that sits between the afferent and efferent arteriole at the control tower of macula densa. That is designed that if you have a situation where you get increased sodium delivery, it will cause afferent constriction to prevent sodium loss, but that should be a short-term effect. If you've got diabetes, what you actually get is exposure of the proximal tubule to glucose, more SGLT2 co-transporter produced. You suck out the glucose, you suck out the sodium, you reduce sodium delivery, and you switch this off, and the afferent arteriole dilates. You get hyperfiltration, increased glomerular pressure that's switched on permanently, and that is the driver of CKD. If you give them an SGLT2 inhibitor, what you get is you block that sodium and glucose resorption. Of course, you get glucose in the urine, which is why it was developed as a diabetes drug, but you get sodium delivery increasing, and you switch that back on. And that's tubular glomerular feedback, and it causes afferent arterial vasoconstriction. Please look at this set of guidelines. Please, if you may want to go through all the evidence. I think this is still very important for you. Look at the recommendations, but also look, if you're interested if you haven't got much time, read chapter 6, because you'll find it is a Reader's Digest version of the guideline, easy to read, a lot of explanation that actually is suitable for patients, but also just suitable to help your understanding. I'm not going to talk about safe prescribing, because you, as diabetologists, need to lecture me on that, as you often do remind me. But very important, you do not use SGLT2 inhibitors in people who've got type 1 diabetes or could have type 2 diabetes with low insulin reserve. So, key messages: a common disorder. Think of it as a cardiorenal complication of diabetes. Early recognition is key. Management is A, B, C, D, lifestyle, finerenone now as well, and SGLT2 inhibitors. Think about glycemic control once you've got GFRs down below 30, about taking your foot off the accelerator, and think about the medications that you can use. Thank you very much for your attention.
Thank you very much, Dr. Frankel, for an excellent and really clear presentation. Does anyone have any questions? Please unmute yourself, or if you write something in the chat, I'll pick it up.
Yes.
Ash, do you want to unmute yourself?
Yeah, thanks, Harriet. Excellent presentation, Dr. Frankel. Just want to ask, in terms of GLP-1 agonists, obviously this patient had an eGFR of 17. Is there any particular cutoff below which you would also recommend not to start a GLP-1?
So, very interesting. Great question. Just if you mute yourself again, the license is down to 15. They're not renally excreted. There is a lot of experience in using them in people on dialysis, which you can do in the United States. And many of my colleagues in the UK are using them on dialysis because they're a great option. No hypos, weight loss. You can give them once a week on dialysis. They have cardiovascular benefit. But I would only recommend that being done through the diabetes clinic rather than doing that myself. So I know the Royal Free and the Royal London have got a number of people on dialysis on GLP-1 receptor agonists.
And Sophie, I can see you've got your hand up.
Hi, that was really helpful. Thank you. With regards to the slide that you did about when to suspect that this isn't diabetic kidney disease, would you recommend that all patients with diabetes, once we pick up that they've gone into CKD, have a thorough screen to look for other causes, or only if those features that you suggest?
So, yeah, so you've got to develop in your thought processes. So I'm seeing this patient, he's got a GFR that's now dropped to 45. What's the history? Is there a progressive history? Do we have that history available? Do they have any systemic features to suggest any other disorder? Do an ultrasound to make sure they're not obstructed. Do a limited renal screen, myeloma screen, ANA, ANCA. But if the immunology is negative and you've got a progressive story and you've got non-alcoholic fatty liver disease or retinopathy, we would not biopsy them. We would label them as presumed diabetic kidney disease. So it's a sequence which I think is just as easy for you to do as for us. But of course, any question, ask the nephrology team. We don't need to see the patients. We could do it through our virtual service or through our e-advice service.
Thank you. That's really helpful. And then just to follow up, at what stage, if it then continues progressing, would you want to see them in kidney clinic? Because presumably you don't want to wait until they need, imminently need dialysis to then see them.
The guidelines are very much depending on when they are likely to require renal replacement therapy. Generally, it's less than 30. We are changing the way we work, though, as nephrologists. Our responsibility is not just to deal with people who are end-stage renal disease, but to improve the kidney health of the people in Northwest London. So we are now much more we're beginning to work in the community with our virtual service, and you'll see those consultations in Cerner. This is where GPs can contact us by an ERS referral. We go into the GP notes, actually into EMIS and System 1, and for 50% of the referrals, we actually put a consultation into the notes, and we're encouraging people to refer to us earlier so we can make recommendations to improve outcomes earlier. So I do not mind any stage you'd be referred, but what I may say is this is all you need to do at this stage, and send them back if there's a deterioration.
Great. And then finally, 2 quick questions from the chat. So what was the name of the GI cation exchanger? So
they are, you will know them as Lokelma and Veltassa. Sodium zirconium cyclosilicate, Lokelma, and Patiromer is Veltassa. And they're now available and used for our acute hyperkalemia, and they're also now approved by NICE for chronic hyperkalemia and to optimize RAS. And we have a standard operating procedure to use them and introduce them, which I'm happy to share if anyone wants to see them.
And then finally, what is your experience of using SGLT2 inhibitors in renal transplant patients? We do not recommend it in our national guidelines because there's no evidence yet on which to base them. We are, however, introducing them, and there is a specific clinic that is run jointly by Joe Reed, I think Chaka, and one of the transplant nephrologists, to choose appropriate patients where we think it would be reasonable to do. We hope there'll be data in the next year. My suspicion is it will be just as beneficial, but it's not something that's currently recommended in national guidelines. So it's got to be done through consultation with the diabetes team. Brilliant. Thank you very much again.
Thank you. And thank you very much. I enjoyed that.
Thank you. Thanks, everyone, for holding on. So it's a real pleasure to have Sharon McCarthy, and I'll let Sharon introduce herself, and she's going to talk about diabetes monitoring and some hints and tips for optimizing CGM interpretation.
Great. So thank you very much. It's nice to see. I've had a look through at the 60 people on the screen, and I do actually recognise quite a few of you guys, so that's good. So my name's Sharon McCarthy. I'm the diabetes nurse consultant. I'm currently working at London Northwest, but I have worked at Hammersmith and at Hillingdon and at Charing Cross and at Mary's, so you may well have set eyes on me previously. So I do quite a lot of endocrine registrar training as part of registrar's placements here at Northwick Park. We do run a clinic today, and I do support the registrars in that way. So thank you very much for inviting me. I don't claim to be as intelligent as our previous speaker, and we're going for more of a practical teaching session today. Feel free to write anything in the chat, and we should try to be as interactive as we can. Okay, host. So as I say, my name's Sharon McCarthy. I've got all my contact details at the end, so if anyone wants some information after that, and I'm sure Harriet's happy to share the slides. Okay, so people living with diabetes, there's no handbook, but we can give guidance. So technology can offer support and on their journey. And so it's a bit like driving a car is the way I try to describe it to patients. So first we had the A to Z. So this is similar to a blood glucose meter. You have to stop and use the map to decide which way you want to go. And it's the same with doing your blood sugars. So you have to stop, you have to check your blood sugar, and it's only a snapshot. It only tells you what the blood sugar is at the time. It doesn't tell you what's happening up above. If the blood sugar is rising, if it's falling, it just literally tells you what it is as you see it. And then in the driving field, we got the GPS, which is great because that starts to tell you different things. That guides you on your way. It tells you if there's a crash up front, you can go a different way. And that's how I relate and explain this to patients. So CGM and Flash, which we're going to talk about today, are different ways basically, and more effective ways that patients can get more guidance. And so we're moving basically from our old-fashioned A to Z onto our GBS for patients with diabetes. It's also helpful because, as you say, that they have a different way of being able to understand where the blood sugar is going. So not just what the snapshot is at the time. Okay, so I've been fortunate enough to be the diabetes nurse consultant on the NICE guidance committee for diabetes, which has been really great. And we've had guidance for some time for people with type 1 diabetes, allowing them to have access to a lot more technology. So CGM, flash glucose, and I know Harriet's going to do a bit of a chat later about deciding of which one is best for which patient, so I won't steal her thunder. And the new aspects of the guidance that have come out recently is that we can offer a choice. So patients can have CGM, which is real-time CGM, or intermittently scanned CGM. So basically they can either have at their preference a CGM where they're seeing their blood sugars all the time, or one where they use flash glucose. And we're going to come on and talk about the differences a little bit later. I suppose the most exciting bit that we've had recently is that actually we're being allowed to offer flash glucose monitoring and CGM to certain patients with type 2 diabetes. And that's really important because I'm sure you're aware we're seeing lots of patients that kind of are having had diabetes for much longer, they're on basal bolus, they don't actually have very much insulin production themselves, and they are struggling to maintain those blood sugars just as much as someone with type 1 diabetes. So that's excellent news. And it's also good for people who, I think we were talking about earlier, who are on dialysis, people who have hypo unawareness, a disability, or they have somebody who they're supporting. So if it's a family member or a healthcare professional that's going in. So if a district nurse is going in to do a blood sugar on a patient, and as I say, the blood sugar is 4.2, do they give 50 units of Humulin M3? They don't really know. If they have access to see that the blood sugar's on the way up, it's rising, or it's been steady, it gives patients and staff and relatives more confidence. So that's the newest bit of technology. You can have a read up, all the references will be on there later. Just a quick note, because I know we are talking a bit about funding a bit later, but the guidance actually for type 2 diabetes for CGM hasn't actually been gone through the financial committees for North West London. So although the national guidance has come out and the London guidance has come out, the actual ability to put pen and paper and get out an FP10 and get it for the patient is not quite there yet, but we're so much further forward than we were previously. So that's great. Okay, so what's the difference? So there is only one flash glucose. So a lot of people just call it Libra, but the actual technology is called intermittent scanned CGM or real-time CGM. So they all offer you continuous glucose monitoring. So the difference is that one, you have to scan to get the result, and the other one that you're permanently being given the result. As you can see, you can use any of these devices, smartphones, you can be connected to a relative who can also see your blood sugars at the same time. The benefits of improving that we have seen improvements on the flash and the intermittent scan glucose is now it also has alarms. So you can set an alarm feature by which if the blood sugar is rising or falling, but you still have to scan. Whereas the CGM, the Dexcoms, the Guardians, these other ones here, whether you like it or not, you get to see your blood sugar. The other benefit of CGM itself as a real-time CGM is that if the blood sugar is actually falling at a considerable pace or rising at a considerable pace, you will get alerts and alarms. However, with the flash, you just get to find out once it's already got to that stage. Now, there's good and bad in that, and we get what's called alarm fatigue. So anyone who's had a bleep for such a long time will know that, if the bleep keeps going off, sometimes you don't even hear it. It's got to the stage where, the alarm's going off all the time, you don't take any notice, and we don't want that. And sometimes with Dexcom that can happen. So it's really important that we train patients to understand the importance of the alarms, and we only set the ones that we actually need to have available for the patients. Okay, so what type of diabetes is this? Anyone got any ideas?
Sharon, shall I go to the Menti?
No, not yet for
Not
this
yet,
one.
okay.
No, yeah. Anyone in the room?
Type 2.
Okay, who said that? Okay.
Okay.
Yeah, actually, this is my Freestyle Libra. I don't have diabetes. Okay, so what I'm trying to show you here is that I was very diligent on the day I wore it for 2 days because I scanned it regularly. But you can see there are fluctuations in my blood glucose levels, and I do have blood sugar levels, glucose levels that are lower when I'm hungry. And I will have peaks in my blood sugars, but obviously they will return because I don't have diabetes. But what I'm trying to show is that even with somebody who doesn't have diabetes, there are peaks and troughs in people's blood glucose levels. And I quite happily had a blood sugar of 3.4 and was absolutely fine and didn't have any hypoglycemic symptoms. So just to kind of be aware that, you know, people without diabetes still have quite fluctuations in their blood sugars. I did try and encourage Harriet and anyone who comes to work at Northwick Park, I will be after them with Freestyle Libras or Dexcoms to try for themselves, because actually it makes you totally paranoid about everything you eat, everything you do, every blood sugar you see. And it's quite a good learning tool because we give these pieces of kit to patients and actually they can be quite intrusive and quite invasive, and actually knowing what your blood sugar is all the time can be quite draining and can cause quite a lot of diabetes distress. So it's not for everybody. It's patient choice, and some will choose, because you might think to yourself, well, why would I choose something that I have to flash and ask for the readings as opposed to having something that I have continuous glucose monitoring? And a lot of patients will say, I just don't want to wear the diabetic t-shirt all day, 24 hours a day, 7 days a week. So it's horses for courses. It's not the same for everybody, and we have to give patient choice. And since the NICE guidelines have come out, that's brilliant. We can offer choice. Okay, so the next slide is one that we do have a little quiz on. So let's see if everybody's still with us. Okay, so can you guess the HbA1c of this patient? Okay.
There we go.
Okay, so 62 is the most common, 52 and 72. Okay, we'll go back to my slides. So HbA1c of this patient was 52. Okay, so I can see why more people went for the middle of the road. But actually, if you look at this patient, they have spent nearly half their day either hypoglycemic or in the low range. And actually, the high range is less of the time. So is that much of a shock to people? I think Eamon and I did clinic this morning and we looked at somebody quite similar. And all I wanted to kind of get across with this is that you can see a patient in clinic with an amazing HbA1c 52. Thank you very much. You're doing a great job. I'll see you in 6 months or a year. But actually, that person has spent a considerable amount of time hypoglycemic, a considerable amount of time with very high blood glucose levels, and a total roller coaster. You know, blood sugar going up, took a correction, blood sugar came down, ate something because they were worried about hypoglycemia, blood sugar going up. This roller coaster is what patients really struggle with. So you can have a HbA1c of 52 and have a flat line here within reason, or you can have a HbA1c of 52 because half your day is low and the other half of it's high. So I suppose what I'm trying to show you is what can we actually learn? So we've got to look behind the HbA1c to see the real story of what's happening to patients. So we know that the HbA1c has limitations. It's only looking at the last 2 to 3 months, and it doesn't show you what's going on behind the scenes. So the new and latest technologies that we have and the kind of terminology we're trying to start to use a bit more is what we call time in range. So time in range is the area where the patient's blood sugar are within a reasonable range. And obviously we know that if we increase the time in range, we can actually decrease the HbA1c by nearly 1%. So it's about trying to get the happy medium as opposed to looking for the excursions and seeing what we can do with them. So let's have a look then, okay, at what you see. So I think everybody probably has seen in their time a Freestyle Libra report. So what's on our report? First thing we have is our glucose statistics and targets. The second thing we have is our time in range. The third thing is our ambulatory glucose profile. And the fourth thing is our daily glucose profiles. So what are we actually looking at? Okay, so the first thing we're looking at if you don't have very much time, and time is limited when you've got consultations, if you just want to quickly assess the patients, just look for their time in range. That will give you a clear idea of how they're getting on. But what are we looking for? So we're meant to be looking for a percentage time in range of over 70%, and that's blood sugars between 3.9 and 10. We want less than 4% low, we want less than 1% very low, and we want less than 25% high and 5% very high. But just generally, if we're aiming for that in the middle of the road, 70%, they're doing a pretty good job. Okay, the next thing we can look at is actually what the HbA1c would be based on them. So many patients come to clinic these days, haven't had a HbA1c done. So you can just about guesstimate what their HbA1c could be based on the last 2 weeks worth of readings. And obviously that's, you know, not beneficial for long term, but in the absence of anything else, you can go, okay, you're not doing too badly. HbA1c, according to this, for the last 2 weeks as being 6.7. And the next thing you can look at is what we call the variability. So the variability is how much these have varied. So getting back to our friend before, where the blood sugars are sometimes 3 and sometimes 23. So the variability we're looking for is less than 36%. So you don't have to remember all this, because good news, Libra write it on the screen for you. So you don't even have to think about it. So if you generally look at someone, time in range is over 70, HbA1c, the GMI there is about in the range, and their variability, you can be quite confident that you're heading in the right direction for that patient. Okay, so this is the slide, the ambulatory glucose profile slide at the bottom is what we look at on the screen. So the first things that we always look at is hypoglycemia, then look at the variability, and then look at hyperglycemia. So this will also help to present the time in range. So the last thing that you can look at is the bottom, which again we were looking at today, Omen and I, for patients to see whether it's a particular day of the week that things don't go well for them. So if there's somebody who says, you know, you notice that on a Monday and a Wednesday they have hypoglycemia, then you might start to ask them questions like, you know, what do you do on a Monday? What do you do on a Wednesday? Is that when you do your gym class? Is that when you're out with your friends? Is that football? That kind of thing. So this screen allows us to compare 2 Mondays, 2 Sundays, 2 Tuesdays. So that's quite helpful as well. Okay, so if we're looking at just a quick case study here. So if you're looking at this patient here who's out walking his dog, Clue is in the picture. The first thing that you'd be looking at for this person out of this big screen here, you might think, oh, well, actually, he's only 59% in target. That's what I must tackle first. But actually, his main problem is hypoglycemia, because he's got a low percentage of more than your 4%. So for him, the main thing that we'd be looking at is for hypoglycemia. So the Clue is a bit in the picture. So what does he do? Obviously, he's more active, and this may be the cause of his hypoglycemia. And again, a bit like, you know, when you have ECGs in the hospital machines, at the end they will offer you this person's in heart block, this person's had an MI, this kind of information. The clinical considerations, if you're in the absence of not knowing what to say to the patient, they often offer you some advice as well. So this advice regarding for this patient says, is this medication going too low? You might want to address the highs and lows. Is he missing carbohydrate? Does his activity levels vary? Is his alcohol consumption varying daily? Again, an example, if you literally look at it and you don't know the wood from the trees, and you've got nothing intelligent to say, you can actually look at what the recommendations given by the download is as well. Okay, and as we can see for him, his actual lows were overnight. So you'd want to start asking questions about what happens overnight. Is it after exercise? Is it is it after exercise that he's doing the night before? Is it drinking? Is it you know, any of these questions? So you can use these recommendations that the Libra will give you to even just start a conversation. Okay, so we talked a lot about, well, I'm helping with the registrars doing some training is about the consultation skills. Okay, so people with diabetes, they do need encouragement, and so no matter what it reveals, we try and start on a good news part of it. For example, you've met a goal, you're doing well, I see you've scanned a lot, that's great, that's better than what you were doing before. And we discussed this even today about, you know, if you say to a patient, have you, you know, do you give all your insulin? The patients will automatically say, yes, I never missed any of my insulin. But if you change that sentence and you say, you know, how long can you get away without giving your insulin? People will go, oh yeah, I can, you know, sometimes I miss it 3 or 4 times. So actually consultation skills are really important. And the other thing that patients sort of feedback as well is, now since I've got a Libra, the doctor doesn't even look at me. They only look at the screen and look at the numbers. So that's really important to kind of take on board as well. So we try and start with something encouraging. That's the first step of our consultation. The second one is, as we were just discussing earlier, is hypoglycemia. So that is the short-term problem, the short-term safety problem, and actually long-term recurrent hypoglycemia can be just as deadly and cause many problems as hyperglycemia. So when we start to look at these downloads, what we're looking for is there any inner blue line, is any of the inner blue line in the hypo range? So is everything going under the range at all? We'll look at bigger ones in a moment. Is it a wide or a narrow band? And the narrow inner blue band where the glucose is low indicates a consistent trend, and you may need to consider changing treatment. If it's a wider band, you may need to look at behavior and lifestyle. So when we look at a few examples, we can go through that a bit more. It will become a bit more evident. Okay, so just here's an example. So as I say, if lots of the blood sugars are under the bottom here, and there's lots of area for improvement, then we have to tackle that area. If there's variability, we have to tackle that. Then we look at hyperglycemia. So we look towards the trends for high blood glucose levels, and if they're persistent, indicated by a high solid line and average glucose, bordered by a narrow inner blue line. So that's the average going across the screen here. So when you see a white space between the upper limit of the target and the upper edge of the outer grey band, it suggests that you may be able to improve the glucose without creating hypoglycemia. So if you understand, we've got a lot of area here under the cloud. So there's a lot of potential for you to make changes without dropping the patient's blood sugar and causing hypoglycemia. So that's important to recognize as well. So it's the area above the clouds, the area below the clouds, and looking at how much, what the average glucose is within the blue line. And the step 4 is looking at variability. So as I say, if we're on a big roller coaster, there's lots of high sugars, there's lots of low sugars, and there's lots of this variability. So high clouds at the top and low clouds at the bottom. That's often due to lifestyle changes and activity and differing diets and differing things, and very unlikely to be a case that you need to give 2 more units of Novo Rapid. So it's just a talking environment where you can say to the patients, you know, what do you think is happening here? Why do you think sometimes it's high? Why do you think sometimes low? What isn't helpful is you look back at 2 weeks and you ask someone on the 25th Monday at 10 o'clock, what did you have for breakfast? I couldn't tell you what I had for breakfast, you know, probably 3 days ago, not allowed that. So that's not helpful. So when we're looking at these downloads, we're looking for more of a broad brush approach, looking for patterns, looking where we can make changes safely, trying not to change too many things at once, and following our stepwise approach. Okay, so we're just going to look at a bit of a case history now. So this is Jean. She's got type 1 diabetes, BMI of 23, had diabetes forever. HbA1c is not too bad. Target range between 4 and 10. She's on quite normal doses, 1 to 10 carb ratio, correction factor, target value, and she takes Levemir. So Jean's problems, if you actually talk to her before you look at her download, is she's got pain, which she's been investigating. She says she's up in the night and she finds it more hard to control her blood sugars. She's struggling with the diabetes. She has big swings. She's suffering with joint pain that's keeping her awake, and she wants to come today to try and improve her glucose in range. And And it's a really good tool. I'm sure you've all seen the tools for consultations where, you know, they've trialed them, where they've got patients out in the waiting room to write down what they want to, you know, achieve in their consultation. And we all have limited time, and it is worth saying to, you know, patients, especially with type 1 diabetes, what's bothering you the most? Which do you want help with? Let's concentrate on one thing today and see if we can overcome that. So step one, we have to be positive. So we look at it and we say, you know, although you're going above the target, the average glucose, which is this blue line in the middle, you know, you're doing relatively well, and we've got something to build on here, Jean. That's great. Okay, so it's our first consultation. So based on what we've discussed before, which area would you start to concentrate on with Jean? Okay, so quite a lot of people are listening, so that's really good. Okay, so I can share my screen. So generally people are looking at the hypoglycemia. That one. Am I back?
Yeah.
Yeah, okay. Yeah. Can we go? Yeah, so people who went for A are looking at the hypoglycemia. So I see why people went for C, because historically we'd look and think, you know, the aim of diabetes treatment is to always get rid of the high blood glucose levels. But remember, we discussed before, you can have fluctuations in the blood sugar levels and have high glucose levels and low ones, and they're just as detrimental. So hypoglycemia has a safety aspect. It's the first thing we should always try and improve on. So the greatest risk of hypo is between 4 and 7. Usually it's the basal insulin's too high, but it may be other things. For instance, when we're talking about Jean, she's getting up in the night. So what's she doing in the night? You know, could it be that she's taken alcohol to try and get herself off to sleep? Could it be that she's tried to do a bit of exercise for her bone pain, anything like that? So it's a discussion point. So why are the blood sugars low at night? And that's the first thing we would always go for. Okay, so the next step we have is looking at, oh, have I gone too far? I've gone too far, sorry. Yeah. Okay, so the glucose above the target throughout the day, this may reflect the acute pain that Jean is experiencing. So if you're in pain, your blood sugars rise, you might eat to comfort, you might be less mobile, she might be someone who previously has been up and active, and now because of the pain, she can't exercise as much as she like. So we have to say to her, look, there's variability in your day, Jean. At what time is the day we have the most variability? So if you were looking at it, which part of the day would you tackle next to look at variability? So would it be A, B, or C?
Okay.
Okay, great. Okay, so 5 people thought it was overnight. 7 thought it was between 7 o'clock in the morning and 1 o'clock, and most people thought it was between 1 and 10. Okay, 1 and 9. Okay. Can we go forward? Okay, yeah, it is between 1 and 9. I don't know what, because I've got the 2 screens up. If I'm showing with my mouse, which can you see my mouse moving now?
Yes.
Yeah. Okay. So yeah, so it is actually between 1 and 9, because can you see the highest variability is there? So this is the average blood glucose. This is the area between that, but the highest variability at that one point is where it's the highest and the lowest. It is quite a lot here as well, but it is much more consistent over a long period of time. So these are the sort of questions we need to chat with her, again indicating what's causing the pain, and looking at, is it irregular timing of the rapid acting insulin? Is it the carbohydrate? Is she missing the meals? And again, this is something we saw today. We saw a patient who regularly had normal glucose levels before they ate, waited for the blood sugar to go up on the Libra, then gave the insulin, waited for the blood sugar to come down, and so their day went on. So it's just really, it's, as I say, again, a talking point so that you can actually tackle the right aspects of the Libra. Okay, so we've seen her and things have gone quite well. We've given her advice about what to do. She started on some painkillers, which is great. And now she's actually managed to come back to see us again. So again, we restart our consultation skills and we say, that's great, Jean, you've come back, you're still scanning. It's much more positive now. Look, you've got less hypoglycemia, in fact, none over here. And things have really improved. So step 1, being positive again. Step 2, we've got got to say, yeah, great, the overall hypoglycemic risk is better. We've actually got none in the low range now. And now we have to start tackling her other problems. So we have to start looking for where else we can help to support Jean. So what we're looking for is the area where under the cloud and overnight in the morning, so there is visible air under the clouds overnight and during the morning. So visible clouds is this area at the bottom here. So there's potential here for us to make improvements to help Jean, because if we bring the blood sugars down, we're not going to bring them to an area by which she would have hypoglycemia. So I've answered my own question, but we'll go with it. So the risk of hypoglycemia at this time is low. Okay, so what we want to do is where there is areas that there is air under the clouds, so something here is your potential time to be able to bring down the blood sugars without risking hypoglycemia. Okay, and step 3, then we want to start looking at the high glucose levels. Okay, so the average glucose here remains high across the day, including before bed, and remains high overnight. There's visible air under the clouds overnight and during the morning, which means risk of hypoglycemia at time is low. So the glucose is stable. So we need to work to ensure that she has a good glucose target going to bed for her blood sugars to be good in the morning. So the sort of things you want to ask, and again, the patient we saw today, exactly this, they had a normal glucose going to bed, but in fear of hypoglycemia, they ate a slice of bread, they had a bowl of cereal, they had a glass of milk. This then brought the blood sugar up overnight, and then we were thinking, oh, we must change the insulin. But actually, it was actually what the patients was doing. So giving them the confidence, they've now got the alarms that they can be alerted if the blood sugars are going to drop overnight, and giving people confidence. It might be that we just move the basal insulin to the morning to give them more confidence, because they feel like they're giving a lot of insulin at night, even though that is not the case and doesn't make much of a difference. Okay, so which part of the day now, we're experts, which part of the day shows the greatest variability of glucose levels? So let's see if everyone's been listening now. So on her second go, which one shows the most variability? So we could try again, Harriet. Okay, great. Yeah.
Yep.
Yeah. Okay, absolutely. So this is the largest area. So this is when the most difference of her activity and her blood sugars are about. So this is the time when you use your consultation skills. This is not the time to start changing the insulin or the medication that the patient's on. This is the time where you use this information to say to the patient, look, it's quite variable. What happened one day? Is it that you don't take your insulin because you're going out shopping, or you're looking after the grandchildren, or what's happening at these times of days? What can we do here to try and make things better? So as I say, there's big clouds here, and this is showing the variability of the glucose. So treatment decisions, we can think about the glucose is stable overnight now, explore why this is the case. Like we were saying, is snacking during the evening, worried about nocturnal hypoglycemia. The variability overnight has improved, but the shaded bands are wide in the afternoon. This may be due to pain at that time. We could reassess the carbohydrate counting skills, the timing of the insulin, giving the insulin beforehand. What we've learned a lot from Libra and all the CGMs is actually patients' insulin administration and the absorption of their carbohydrate and glucose is miles apart at times, especially even with Novo sluggish. We really do struggle with people getting that timing of their insulin correct. So these are the sort of things that we can make choices and decisions and offer advice with. Okay, so just getting on, so we've got some time for some questions. The important things that you can take away and the way that you tackle it from stepwise is try and get a perspective on it. It's important to keep perspective on it. Look at the whole thing. Look at previous appointments. People with diabetes probably don't look at those readings. They look at their handset, which is just basically an up and down V and W. So getting them to look at the screen and looking at patterns is very good. Always try and focus on the glucose levels overnight before going to bed and waking up, because if half your day is spent in the higher range or in the lower range, this will have a massive impact on your HbA1c. Look at medication, but ultimately it's a lot to do with lifestyle and behavior and changes, and look at different things. People can take different doses of insulin on different days based on what they do. You know, if you have a very active job Monday to Friday and you spend Saturday and Sunday relaxing, or the other way around, it's not unheard unheard of for people to take different amounts of basal insulin on the different days. And always sense check your assumptions. Let the patient tell you. Don't always presume you know better by just looking at the screen. And again, the feedback from patients is that, you know, people look at it and, you know, they already feel guilty and feel that kind of burden of diabetes. So we don't want them to feel that we're analysing every blood sugar and every activity. And the last few things is to tackle one issue at a time. During a diabetes consultation, we can't just try and go, oh, I see they're high in the morning, I see they're low at the night, I see you've got variability. Pick one thing, ask the patient what they want to focus on, and then don't forget the diabetes nurses. Obviously, we're here to support that in between the doctor's appointments. Try and ditch the technology jargon, you know, talking about hypoglycemia. You might want to talk about it in a different way. You know, I often say to people, you know, have you felt dizzy? Do you feel, you know, clammy? Are you hungry in the night? Do you get up much for a wee? Those kind of questions, as opposed to trying to use the technology and the jargon. And explain the value of daily logs. So that's the other thing that we can do is, you know, it's unrealistic for every patient to write every amount of carbohydrate they have and every dose of insulin that they take every day for the rest of their lives. But if you're struggling with one area, you can say to them, look, just for a week, input onto the Libra, how much carbs you're taking, how much insulin you've taken, and let's see if we can just do a bit of a recap for a short period of time and work out why things aren't going as well as we would want. Look at all the issues. Their individual traces can be important to detail to the insights from the AGP and can be used for further to understand the patient's story. For example, significant variability can be caused by weekends, which we were discussing, and they're not always revealed on the AGP. So it can make sense to investigate weekday, weekend tools. A pattern of low blood sugars may reflect the combined insulin doses, exercise, carbohydrate intake. So it's basically a joint decision between you and the patient. And I say it's all about consultation skills. These are the sort of words that we use: air under the clouds. So what we were discussing, significant hypoglycemia, billowing or ballooning, where it's showing high areas of variability, roller coaster, where the blood sugars are just going up and down, and the merry-go-round of take more, eat less, have to eat more, take more, and trying to, you know, get rid of the merry-go-rounds, because that's actually what the patients find the most frustrating. And when you give someone Libra or CGM for the first time, they react to nearly every blood sugar. Either I don't eat because my blood sugar's high, or I eat more because my blood sugar's low, and it can become a real burden. And some people just literally don't want it. They take it off and they can't cope. So it's important that we're giving the right device for the right person. And my other biggest bugbear as a diabetes specialist nurse, and anyone who's sat in clinic with me will know, is that the most important thing and that can cause the most variability can actually just be the simplest of things, and that can be injection sites. So if patients have areas where they've been giving a lot of their injections in the one place, giving 10 units in here, or 20 units or 30 units can make such a difference if you actually just move their injection sites. And my other big bear is people changing their needles. So obviously this is magnified, but if you don't change the needles, you will get lipohypertrophy and lipodystrophy much quicker. So I will stop sharing now. Can I do that? Or I can leave that up. So if happy to take any questions or any advice that people would like about how to look at the Libras or CGM, or anything about technology generally.
Has anyone got any questions? Feel free to put your hand up or to write something in the chat. Yeah.
Apologies in advance, but how often should we be checking that patient change their needle? Why does the blood needle cause hypertrophy?
Yeah, so basically a patient should be changing their needle every time they give an injection, because we know for two reasons. One, if a blunt needle will cause trauma to the skin and cause the lipohypertrophy and dystrophy to develop quicker. But two, also, if you dial up insulin and you continue to leave the same needle in, you will develop air bubbles within your pen. And so if people don't do the air shots, when you're actually dialing up 8 units, one day they might be getting 8 units and the next day they might be getting 6, because they're actually only giving, if you think if you're on quite small doses, a dose of insulin, like a unit of insulin, if you put it into your hand, is very little. And so especially on the concentrated insulins as well. So yeah, so we should be encouraging patients to change their needles with every injection, and they shouldn't leave their needles on the pen. So you might say to patients, oh, have you got your insulin with you? Pull off the lid and just have a look and see if the needle's there, because it does make a big difference.
Great. Got a really good point from the chat about potential compression lows overnight. So can Libra record full slow reading, especially at night time, if the patient sleeps on that side?
Yeah.
Due to pressure?
So I think as wonderful as Libra is, it's not, how can I put it? It does, you've got to look for the patterns, you've got to look for what's happening. And if patients, are saying, I'm getting a lot of lows over bed, you're absolutely right. If you lie on any of the CGMs for long enough, it will show lower readings. But if you think about what people have had before, at least this is alerting them that the sugar may be low. Yes, it may be the way that they're lying, but at least it will keep them safe and will alert them to wake up and change that area, change movement, and you will find out if the patient is okay. But you're absolutely right. I think once people go on to real-time CGM, they never go back, even if they don't look at it all the time, because the lag is less. So, if the blood sugar is dropping, for instance, and you check on a Libra and your blood sugar is saying 3.2, and then you recheck and you take glucose, your blood sugar will not go up over 4 very quickly because of the 15-minute lag. So it's about education when we give the devices to the patients to say, like, if your blood sugar is low, recheck with a blood, finger prick, and if your blood sugar is starting to go up, make sure, or seem like they're not going up, recheck with a blood glucose meter, because that's the best way to check as well. There is a way, obviously, as I say, to share the glucose readings with a friend or a relative or a colleague. Even on the Libra, you can do that as well. So I think Libra has meant that so many people have had access to a form of CGM that they would never have had before. Is it the gold standard? I think if it was up to me, I'd have real-time CGM. But then if you talk to patients as well, they're very much like, I really don't want to know what it is all the time, and that's actually causing more distress for them. So I think it's different for everybody. But you're right, it can, if and if you're very hot, it can fall off, and if you put cream on, it can fall off, and there are many things. But it does mean that patients can go to their GP, get a prescription, and there's no funding issues. There's no, have you been good enough to be allowed to have it for the future? All the punitive things that makes people with diabetes feel a bit kind of like they've got to prove themselves or do something to be able to get things, and if they're naughty, we'll take it away from them. There's been real benefits of having CGM for patients.
Great. So we got a question from Sophie. Do you want to unmute yourself?
Thanks, Sharon. Could you just explain a little bit about the Libra 2 and the alarms?
Yeah.
I've never really got my head around the idea that you have to scan it, but it has an alarm function.
Okay, yeah. So it's permanently working on Bluetooth. So it's permanently knowing what the blood glucose level is, but it's not showing it to you. You have to ask what it is. So your phone or your handset is permanently getting those results. So it knows if your blood sugar has dropped to a certain level, and it's asking you to check and confirm. So when you check and confirm, it will do it. So that's the difference. So it's real time, but blinded to the person, if that makes sense. So that's the newest technology. And then obviously there's Freestyle Libre 3, which is real time CGM. The negative thing about that is, unfortunately, it's not on prescription. So that involves a funding request, an invoice, a PO number, and a lot of hassle. And so that's quite frustrating. So things like Dexcom One, I'm sure you've heard of, is the CGM that's probably going to be quite popular, available on FP10. It does similar things to the Freestyle Libre 3, and people will be able to get that from their GP on prescription. So I think moving forward, a lot of the patients who are on Libra are already knocking on our door saying, when can I have my Dexcom One? And as I say, the guidance is just yet to come. to come out. Well, the guidance has come out, the money hasn't quite followed, because obviously there's a significant difference. Although Dexcom One is similar price to Freestyle Libre, I don't know if you kind of realise, so a Freestyle Libre sensor is about £50 for a patient to buy. It costs the NHS something about £30 odd. Dexcom G7 or G6 is about £2,500 a year. So it's a significant difference of funding. So yeah, so obviously people who have proper hypoglycemia unawareness, the sort of people that I used to look after at Charing Cross, who would, you know, be found, bless them, on the train tracks before you'd know it because they had hypoglycemia unawareness, those kind of people, they should not be on these devices. They should be on proper CGM.
Okay,
so yeah.
Just in the interest of time, we've got one further question from the chat. For new diagnosis of type 1 in children less than 16, so I don't know if this is something you feel comfortable answering, but which is better, real-time or intermittent CGM?
Yeah, so I mean real time for people, for children, because the parents can obviously have it on their phone or on their device as well, and that's the key. You know, if your child gets diagnosed with type 1 diabetes at UCLH, they'll go home closed loop these days with a pump and CGM. So, you know, I think we are changing the way that we start. I don't think, how can I put it? I think it's very important that people can blood test as well, because as you say, you know, if you scan a Libre and it's saying your blood sugar's 2.1 and you're sitting absolutely fine, then, you know, you want to be able to recheck. And I think if we give people CGM from day one and they never check their blood sugars, I don't think that's very safe either. So I think we have to, you know, start with the basics, but give people the technology and then try not to get them to focus too much on every single glucose. And I worry about people who actually, when I showed you my CGM, obviously I was making a bit of a, you know, point, I was scanning every hour. I worry about people who scan every hour. They shouldn't be on they shouldn't be on flash, they should be on real-time CGM, because that's what they need. And if you have to scan every hour, you know, that's not great.
I guess that's a whole nother debate, isn't it, about when is really the best time to start people on technology.
Yeah, technology,
but
yeah.
Thank you very much. That was a really fantastic presentation.
Yeah, so
sorry, go ahead.
No, I was just going to say, I'm happy, you know, anyone who knows me, who's worked with me, I'm happy to go through individual ones if they want to email me and have a look. And, you know, sometimes you just can't see the wood for the trees and you have an example. It's really good to have the example, because obviously the ones we made were made up ones. But if you actually have ones you want me to have a look at, that's absolutely fine. We could talk through and do some training. I'm happy to do that.
Thank you. Okay, so we're going to move on to some insights from the transition clinic. So I'm going to hand over to Shayla Khan, who is a diabetes and endocrine trainee in Northwest Thames. So we're going to kick off with some Menti questions. So if everybody can type 3 words that come into their minds when in regards to transition clinic. Oh, let me try that again. Transition clinic or young adult diabetes clinics. This is going to be a word cloud. Okay, so results should start appearing once people type in.
Or Harriet, what we can do is we can just leave it open and I'll come back to it.
Yeah. Yeah.
So you've got plenty of time. It's totally anonymous, so you can write whatever you like within reason. And I'll start sharing my screen. Okay. So my name is Shayla Khan. I'm one of the
Sorry, Shayla, I don't think we can see your screen this end.
Oh, okay. Let's see. Let me go back to sharing my screen.
Yeah.
Yeah. Okay. Great. So, hello. I'm one of the endocrine registrars at Imperial, and I'm going to be talking through some cases from the young adult clinic at St Mary's Hospital. Okay, so if we, Harriet, if we can move back to our word map and see what came up. Okay, so challenging challenging, change in target HbA1c, self-management, psychotherapy, loss to follow-up, compliance, pediatrics, 16 to 18, difficult communication, growth hormone, hard, difficult. Yeah, okay, well, that's pretty interesting. So I will start sharing my screen again and go back to my presentation. Okay, are you able to see that?
Yep.
Okay, so what is transition? Transition describes the time when a young person moves from one diabetes service to another. This is generally a major milestone, and the age at which transition occurs can be variable depending on individual circumstances. And I've got another question for the Mentimeter. So what proportion, so if you move back to your Mentimeter, what proportion of people with type 1 diabetes transition from peds to another service between the age of 17 and 18? So what proportion do we think that they move? Okay, so yes, most of you are right. The answer is 65%. The majority of people transition from pediatric care around this age, but there is actually a decent spread. They're clearly not all moving at that time. And the reasons can depend on local service variations or individual circumstances. Essentially, there is no specific age for transition. So why does transition matter? From a healthcare data point of view, we know that clinic attendance reduces. There's often a deterioration in glycemic control. The rate of DKA goes up substantially. So we've got amongst 18-year-olds are 7 times more likely to be admitted for DKA when compared to 12-year-olds. And that's data from the first National Diabetes Transition Audit in 2017. And the same audit showed fewer achieved their HbA1c targets. Finally, as the cohort grows older, early complications may begin to present. All of this is highly relevant to us, especially as approximately 80% of the NHS diabetes spending goes on managing complications that possibly could be prevented. And from our patients' perspective, what did they experience during this time that might be relevant to their diabetes? Well, the answer to that is, of course, quite a lot. During this time, a major change will, there'll be several major life events are quite likely. The major one being a move from parental care to independent self-management. Other events might include changing school or college, starting university, which is a big one, moving away from home, starting a new job. All these changes come with a change to routine, change to eating time, change to activity patterns, and lots of new considerations to think about, all while checking blood sugar glucose levels, insulin doses, timing of injections, preventing hypos and avoiding too high. It's a lot. And there are likely to be a host of psychological stresses that come with this time in life. There might be stresses associated with exams, relationships of all kinds with family members, friends, and others. Finances and employment may bring concerns too. Moving house, new people, new colleagues, new friends, new partners, new support systems. A lot of change. And physically, young people are still growing, sometimes into the early 20s. There are inevitable changes in height, weight, and body composition, all of which will result in changes to insulin requirement. So here are some of the aims of the transition services. During transition, we aim for a smooth transfer to adult care. We want to help support people to be independent and boost confidence in self-management. We want to encourage continued engagement with the services. And we want it to be a positive experience. And of course, we want to help people achieve that good glycemic control in accordance with their personal goals. So how does care differ? Let's look at paediatric clinics from purely an aesthetic point of view. So here we are, some photos of some paediatric clinics from across the country. So not very colourful, they look like peds clinics, think you know where you are. And let's remind ourselves of adults clinics. So it's fairly different. It's fairly different, that's all I'll say. But let's look at other ways in which care will differ. So the physical location will change, but also the frequency and length of appointments. Critically, patients will be introduced to new staff. So new doctors, nurses, dietitians, even reception staff. And the procedure for emergency care and their emergency contacts will change. What we have to bear in mind is that some of these patients will have known these staff members for years, some of them for their entire lives or as far back as they can remember. These staff members have played profoundly important roles in people's support systems and help provide a sense of safety. And transition, whether in reality, is a time when that's going to change. Furthermore, there may be changes to the care itself, including new targets, and they'll certainly come across a new mixture of patients in the waiting room, some of whom may have developed complications. For the patient, a huge change is with autonomy. Once they're adult, patients now have autonomy over all their medical decisions, as well as rights to confidentiality. And again, a huge part of transition is this move from parent-led care to independent self-care. So this slide shows the transfer journey at St Mary's Hospital. So the last appointment in the Children's Centre will happen just after the 16th birthday. After that, appointments will be in the teenage clinic, which happens in the Mint Wing, which is essentially a different physical location where also the young adult and standard adult clinics take place. And this provides gradual easing into the move. At the teenage clinic, appointments will be alternated between the children's team one time and then the adult team next time. Then after around 19, we aim to see them in the young adults clinic, which is 19 to 23, and they will see the same team each time, and it's a dedicated service for people aged 19 to 23. And then once they turn 23, they are moved into the general adult clinic. Now, how is transition managed? The answer to that is gradually and with lots of planning. Conversations need to happen early. The introduction needs to be gentle, avoiding overloading with too many appointments. We have to continue the MDT approach, and patients need to be supported to get to know the new members of their new team. And there might be some new medical aspects, such as foot reviews or some new targets. And a large aspect for care for young people with diabetes is psychosocial support. It is really key to use a person-centered approach in general in diabetes, but really is key for young people. So getting to know our patients and letting them know that we see them as individuals and not their diagnosis. Exploring how they feel is so critical here. So how do they feel about their diabetes? How they're feeling about transition? How they're feeling about their new staff they've met? It's also really important to get to know them as people. So we need to ask about what are their hobbies and interests and plans for the future? What's their motivation for staying healthy? All of this will provide really rich information for us to figure out how to best support them and get a better idea of how diabetes fits into their lives. We should be asking about mental health as part of normal standard care. We know that diabetes can be difficult to manage, and there's a higher risk of depression, anxiety, and eating disorders. We should be asking about diabetes distress and aiming for early intervention, as this is known to be associated with poorer outcomes in the long term. So some key areas of discussion. Moving to university is a big one. People are leaving home. As I said before, new routines, new activity levels. It may also be a bit of a shock for some people who thought they had been self-managing at home for years, but in actual fact, they've been in the highly structured routine of school with lots of support there at school, and also they've been living at home with their families. And once that's lost, that can weigh quite heavily. A new job is also a major milestone. Again, there's new routine, new pressures, possibly stress around disclosing their condition, possible fear of discrimination. Next is relationship, dating, sex and contraception. This is a great opportunity for young people to ask questions in a safe space. For example, many young people now use pumps, wearable and monitoring devices. How does all that fit in with the above? Equally, it's great opportunities to discuss drinking alcohol, managing nights out, drug use, all in a safe and non-judgmental space. And then finally, again, there's mental health, which we said should be asked about as normal care. Here are some ways in which the services can be adapted to improve the experience and engagement with young people. So improvement to waiting rooms can make younger people feel more welcome in clinics. So that's decor, somewhere to charge the phone, actually relevant literature, and meet the team boards. Group sessions and social activities allow people to meet others with diabetes, form networks, find peer support. Use of technology. Some services are using WhatsApp ahead of appointments to send reminders. Many of us are offering video appointments as well, which are likely to appeal, require less time off work or less time off school. And then departments can keep updated websites or maintain social media accounts, perhaps uploading videos that might be relevant to young people. And so to summarize, transition is a very vulnerable time for diabetes care. We know that people are at risk of a deterioration in their diabetes care for multiple reasons. We've discussed various barriers to self-management, including major life changes and changes to routine, support and activity. And there may be a wide range of life stresses that make diabetes care more difficult. In order to support people through transition, a collaborative and consistent approach is what's required throughout. And that's the end of my talk. Thank you very much.
Thank you very much, Shada, for such a fantastic overview of what's a really, well, quite a complex service with some really insightful cases. Has anyone got any questions? Feel free to put your hand up, or again to put something in the chat. Can't see any at the moment. Okay, so just in the interest of time, I think we'll move on to the next presentation, which is from myself. So, okay. Okay, so hopefully everyone can see my presentation. I'm going to stick with this for now. I haven't got any notes. Can everyone see? Yep. Okay. So I'm going to talk a little bit today about the new Pan-London implementation document for continuous glucose sensors for adults with type 1 diabetes. So this came out in October of this year. Some of the decisions around funding locally haven't been decided, but I'll take us through it anyway. In March of this year, NICE updated their guidance to recommend that anyone with type 1 diabetes be offered either real-time or intermittently scanned CGM but also patients with type 2 who are at risk of hypoglycemia or are needing to monitor frequently. So generally patients who are on insulin, possibly on sulfonylureas, should also be offered CGM. So thinking about things to consider when deciding on a choice of sensor. Although this guidance came out in London, really some of these questions actually should be applied to anybody. So firstly, we really need to think about what sort of alarms someone will need for hypoglycemia. We need to think about whether the sensor is compatible with a pump for automation, if that is something that the patient may be going on imminently. We need to think about the data sharing ability. So generally that's next of kin and healthcare professionals. Some devices will offer sharing ability for both of those groups, some just with healthcare professionals. And that's particularly important for people who are perhaps more frail and essentially need to be able to share their data with other people. Does the system require calibration with glucose readings, so capillary glucose readings, and are there any pregnancy plans on the horizon? So just quickly, this hasn't been sort of clinically verified, but this is one approach to thinking about a hypoglycemia history. It's the 4F hypoglycemia history approach. So this is thinking about the frequency of hypoglycemia, thinking about whether the patient has impaired awareness. And one way that you can measure that is using the GOLD score. Thinking about, is there any fear of hypoglycemia, and is that driving the way that the person with diabetes is using their insulin? And the force, so thinking about whether they've needed third-party assistance for a hypoglycemic episode, particularly important in thinking about the context of driving. Has there been an episode where they've needed help in the last year? And again, important to ask whether that's been overnight. So this is just a reminder about continuous glucose monitoring arrows and trends. This is adapted from the Diabetes Technology Network guidelines. And essentially, this just gives you a quick overview of the three sort of main systems that we are familiar with. So Dexcom G6, Medtronic, and Freestyle Libre 1 and 2. I won't go through it totally, but just kind of, I think it's quite useful just to have an idea. So when you're talking to patients, you kind of know what the arrows mean. And in particular, I think it's helpful to know how much the sensor glucose changes in 30 minutes. So what will happen if you don't take action for 30 minutes? And as you can see, really, the highest and lowest arrows suggest that there'll be a change of more than 5 millimoles per litre in 30 minutes. Now, in addition to this, all CGM devices will offer low glucose alerts as a feature, and the level they are set at can be altered. So we have optional low glucose alerts, so they're optional. We have mandatory or fixed low glucose alerts. So these operate at a fixed glucose level, generally 3.1 millimoles per litre, and cannot be silenced or turned off. And essentially, they're there to prevent dangerous hypoglycemia. And then more recently, we've had the introduction of predictive low glucose alerts. So these are advanced warnings or alerts for when a blood glucose will drop to a certain level. Generally, these are customizable, and it means that the person can take preventative action. So this is just an example from Dexcom. So this is the urgent low soon alert. So that's designed to provide a 20-minute advance warning. So advance warning that you'll reach 3.1, giving you time to act. Okay, so hopefully you can all see this flow chart. This is basically the flow chart from the Pan London guidance, essentially helping you make that decision about which sensor you're going to offer. So if we start at the very beginning, so if we think about the problematic hypoglycemia, so very quickly, that's one or more episodes of severe hypoglycemia in the preceding 12 months, impaired hypoglycemia awareness, and or more than one episode of asymptomatic hypoglycemia a week, and or fear of hypoglycemia. What should we be offering people with problematic hypoglycemia? Well, really what we want to be offering them is something with a fixed low alarm and an optional predictive alarm. So as you can see, these are the 3 options at the top that will offer you these things. This is specialist real-time CGM. So this needs to be initiated in secondary care. So it won't be available in FP10. And as I say, we initiate it in the hospital, we'll write to Dexcom and Medtronic, and then going forward, these companies will supply sensors and transmitters to the person. We also have Dexcom G7, which does have a fixed low and an optional predictive alert, although Dexcom G7 isn't available yet in many trusts. So that's our problematic hypoglycemia. If we then move on to those thinking about using an insulin pump, it's really the same sensors. So again, Dexcom G6 and Medtronic are compatible for automation. Does everyone know what I mean when I talk about automation? Does anyone? So automated hybrid loops have recently been established where the sensor will communicate with the pump to augment insulin levels. So there are a couple of different systems that are out. One system will do something called predictive low glucose suspend. So if a glucose level is predicted to go to a certain level, it will cut off your insulin supply, or it will basically suspend your insulin pump. So that's systems such as Basal IQ. But then you've got systems such as Control IQ and Smart Guard that work slightly differently. And essentially, they work at getting you to a target blood glucose. So they basically are trying to eliminate both hypo and hyperglycemia. So we've got the 2 types of automation, essentially. Does anyone have any questions about that? Please just unmute yourself and ask, because I'm afraid I haven't got the Zoom screen open. No. Okay, so as I mentioned, it's really the Dexcom G6 and the Medtronic that currently are available to loop with pumps. Oops. Then if that doesn't apply, we think about whether there's a strong clinical reason for data sharing with friends and or family. And really here, there's a suggestion that specialist real-time CGM should be used, really because perhaps that vulnerable person is not going to remember to scan or is not going to be able to scan. And I won't go through all of them, but essentially, these are the specialist real-time CGM options. And here again, you can see that there are several options that share with healthcare professionals and with relatives and carers. Some of them are just with healthcare professionals. And then finally, if that doesn't apply, you want to think about offering the individual a choice of intermittently scanned or real-time CGM. So as Sharon mentioned earlier, some people really actually don't want to know what their blood glucose readings are all the time and actually would prefer to scan. It's important that when you think about this cohort of patients, that the real-time CGM system is available on the FP10. And that's because essentially it's going to be the GP who's going to be supplying it to them. It generally will have optional high and low glucose alerts. So these are participants who are not at high risk of hypoglycemia. They're not the problematic hypoglycemia group. And again, for these people with diabetes, they don't need to have connectivity compatibility with a hybrid closed loop system. And they don't necessarily need to share their real-time CGM data with healthcare professionals, friends and family. So these are the main options that should be available in FP10. But as I mentioned, there may be some slight discrepancies between trusts. Freestyle Libre 2 is currently the only one that is intermittent scanning. So as Sharon mentioned, Freestyle Libre 3, which is real-time CGM, again, can only be started in by hospitals. And then you've got 3 other options. So the Dexcom 1, Glucose Aidex and Glucomen Day, which are all real-time CGM. As mentioned, they're not compatible with pumps and they have optional high and low alarms. Quickly just mentioning pregnancy. So essentially, if there's no problematic hypoglycemia, offer a real-time CGM system with optional non-predictive highs and low glucose alerts. And then again, if problematic hypoglycemia, real-time CGM with mandatory fixed and predictive low glucose alert features. So really anyone who's pregnant or thinking about getting pregnant should be on real-time rather than intermittently scanned CGM. And then just very quickly to mention driving. So this is just group 1 drivers. So essentially you can use real-time CGM and Freestyle Libre whilst driving, but essentially you need to do a confirmatory finger prick if your glucose level is 4 or below, if you have symptoms of hypoglycemia, if there's inconsistency with your symptoms. And alarms on the real-time CGM must not be used as a substitute for symptomatic awareness of hypoglycemia. Just a couple more slides just to mention something called the Academy. So this is something that's been started by the Diabetes Technology Network. It's an online platform that provides some educational support on various topics within diabetes technology. It's well worth doing. You can do it at your own pace. So please do get in touch with them. Your local centre will need to have a Gluco Academy account in order for you to register, but it provides really good bite-sized learning for technology.